Good morning, class. This is Allison.
This is Maddie.
This is Dana.
And today we're going to be talking to you about peripheral artery disease. So make sure that you pay attention because there's going to be a quiz at the end. Okay, so what is PAD, peripheral artery disease? That is the thickening of the artery walls, and that is most likely caused from atherosclerosis, and that is the hardening of the arteries, and that's where that cholesterol and lipids, they build up and make the artery pretty narrow. So some risk factors for PAD. So if you already have diabetes, hypertension, high cholesterol, or even being over the age of 60, this puts you at higher risk for developing PAD.
Okay, so how does PAD manifest itself? One of the classic symptoms is intermittent claudication, that is pain that is increased with movement, such as exercise and walking, and then it is resolved shortly after rest. Sometimes it'll last about 10 minutes. Paresthesia, which is numbness or tingling in the toes or feet, and that occurs from the result of nerve tissue ischemia. We also have thin, shiny, hairless skin. Sometimes that portrays itself in the lower extremities, the legs. We have decreased or absent pulses, and then we have rest pain. So a lot of times that occurs more often at night due to an insufficient blood flow. That can be chronic sometimes, and that is called critical limb ischemia. That is chronic ischemic rest pain lasting more than 2 weeks. And that kind of has symptoms such as non-healing, arterial leg ulcers, or gangrene. And risk for that is diabetes, heart failure, history of stroke.
How PAD is diagnosed? The Doppler ultrasound can determine degree of blood flow, the MRA's location and extent of the PAD, and the ankle brachial index compares blood pressures of upper and lower limbs, and that's done with a handheld Doppler, and that's the most common one to diagnose it. It's calcified and stiff arteries in older patients, and those with diabetes often show a falsely elevated ABI.
In the previous slide that I talked about with clinical manifestations, I repeated the word ischemia, and that is very important in PAD because this ischemia can cause multiple complications such as atrophy of the skin and underlying muscles, wound infection, tissue necrosis, or even feet ulcers. This is due to delayed healing. And again, like I said, with the arterial ulcers, they are more predominantly over bony prominences. The most serious complication is amputation, and that's just because blood flow is not restored and that severe infection that I was talking about truly occurs, and that is indicated with uncontrolled pain and spreading infection.
Okay, so as the nurse, it is super important to get a good history and physical on our patients. So asking a couple questions like, what helps alleviate the pain? If your patient says dangling helps or elevating their legs make it worse, that is a really good indicator that they have PAD. So dangling the legs, they will become more warm, and so that is the increased blood flow. And elevating their legs will become pale, and that's impeding that blood flow. Another question to ask is, can you explain your pain to me? If they explain it as a rest pain, worse at night, or pain with activity, which is that intermittent claudication, that is a really good indicator as well that they have PAD. So some objective assessments that we can do. So assessing the skin. If their skin is cool to touch, there's a perfusion issue, which is that decreased blood flow. If their skin is thin or dry or scaly, and if they have hairless legs, with their feet, if they have thick toenails, those are some good indicators. For the pulses, if they have very poor or absent pulses, and edema. So edema is not usually common with PAD, it's more common in PVD. And also looking for any lesions on their feet, ankles, or toes that is also a really good indicator of PAD.
Teaching patients how to modify their risks of developing PAD is essential. Controlling hypertension, which includes decreased sodium in the DASH diet. The DASH diet is dietary approaches to stop hypertension, which includes fruits, veggies, fat-free milk products, whole grains, and less red meat and salt. Tobacco cessation is essential to reduce the risk of cardiovascular events. Diabetes is a major risk factor for PAD and increases the risk for amputation. Also, controlling cholesterol levels with diet and lipid management.
All right, so in our plan of care, we always are going to have drug therapy. So to start off with, we have the angiotensin converting enzyme inhibitors, the ACE inhibitors. Those are your prils. One of the most common ones is ramipril. That is because it reduces your PAD symptoms, such as it decreases mortality, increases peripheral blood flow, and the test that Dana was talking about, the ankle brachial index test, it increases that, and it increases walking distance. Also, for the antiplatelet agents, we use clopidogrel, which is also called Plavix, and then we also use aspirin. The intermittent claudication, the symptom that I was talking about earlier, there's two medications for that, which is salidazole, which is also called Pleadel, and then there's pentotoxifylline, which is also called Trental. These two increase vasodilation, they improve flexibility of the red blood cells and white blood cells, and they decrease fibrinogen concentration, platelet adhesiveness, and blood viscosity.
Lastly, as a nurse, how do we implement control of PAD? It is important to teach our patients the risk factors for developing PAD and how to control those risk factors. Diet modification, reducing cholesterol. Exercise decreases CVD risk factors. Walking is the most effective exercise with intermittent claudication. Teaching importance of inspecting feet daily to decrease risk of foot ulcers and or infections, and also assessing the patient's knowledge of the disease and getting them involved in their plan of care.
All right, y'all, so we're going to quiz you with a little game. Everyone split up into groups of 5 and go to the link below.